The following podcast is part of a certified educational activity titled Navigating Multifactorial Clinical Decisions in HR-Positive Early Breast Cancer and Metastatic Breast Cancer, a case-based algorithmic guide. Access the entire activity and complete the post-test at peerview.com/RAX860. Downloadable slides and practice aids are also available.
All right. Good evening, everyone. Thank you so much for coming in here today. We have an exciting session planned today. It is going to be covering navigating multifactorial clinical decisions in hormone receptor positive early and metastatic breast cancer, and really a case-based algorithmic guide. So really looking forward to your interaction, your questions as we walk through these data together. Now, I'm Komal Javeri. I'm a breast medical oncologist at Memorial Sloan Kettering Cancer Center, and it's really a pleasure to be joined by two excellent friends, colleagues, faculty members here. We have Dr. Sarah Hurwitz, Professor of Medicine, Smith Family Endowed Chair in Women's Health and Division Head for Hematology and Oncology, also Senior VP for Clinical Research at the University of Washington Medicine and Fred Hutch Cancer Center. And joining also today is Dr. Javier Cortez, who is the head of International Breast Cancer Center and in Barcelona, Spain. And so really looking forward to having an excellent discussion with both of you today. Thank you for joining us. The three important goals for today's discussion are to augment our knowledge of the latest therapeutic options for hormone receptor positive, HER2 negative, both early and metastatic breast cancer, to equip us with strategies for optimal risk assessment and biomarker testing to inform treatment decisions in hormone receptor positive, HER2 negative breast cancer. And last but not the least, improve our skills in both selecting and sequencing treatments for patients with early stage and for advanced hormone receptor positive breast cancer. So Living Beyond Breast Cancer, just a quick word. This is our patient advocacy partner, and they really provide trusted information and a community of support to all the patients with breast cancer. And so certainly feel free to access and share supplemental downloadable resources made available as part of this activity with your patients. I think patients find this very helpful. This is from patients for patients, so I think something really helpful to consider. With that, let's begin our first module, which is focusing on clarity when the goal is to cure, evidence and practicalities for management of hormone receptor positive, HER2 negative, early stage breast cancer. We'll start with a case. So this is a 63-year-old postmenopausal woman who underwent a routine mammogram and was found to have a mass in the left breast. Breast imaging confirmed a 4.5 centimeter mass and enlarged suspicious axillary lymph nodes. Core biopsy done revealed invasive ductal cancer that was grade 3, ER positive, PR positive, HER2 negative. Lymph node biopsy was consistent with breast cancer cells as well. Staging scans did not show any evidence of distant metastatic disease. Germline testing was performed and did not show any BRCA or PALB2 mutations. Patient underwent a left mastectomy with axillary lymph node dissection. This revealed a 4 centimeter tumor, grade 3 invasive ductal cancer. 1 out of 3 lymph nodes were involved. An oncotype was sent, and the recurrence score came back as 21. Comorbidities: patient has history of bipolar disorder controlled on quetiapine therapy. She's come to your clinic to discuss results, risk of recurrence, treatment options, and next steps. For that, I think I'm going to have Dr. Hurwitz walk us through all the data and tell us what does she think, or what should we think after she talks to us about these data.
Thank you, Dr. Javeri. So let's talk about adjuvant CDK4/6 inhibitors and where the data sort of lands us on a case like that. And first, let's reflect on real-world data that we have relating to what is the risk of recurrence for patients who have node-positive, ER-positive, HER2-negative breast cancer. It's interesting to note that although we think of patients as being fairly low risk, given the tools we have available in the curative setting, 30% of patients from real-world data with node-positive, high-risk, hormone receptor-positive breast cancer do experience disease recurrence within 5 years of standard endocrine therapy and would benefit from intensification. There was a real-world study of patients from the Flatiron Health database that did demonstrate an increased risk of recurrence in a patient population that had features that were similar to patients enrolled in the Monarch E study. So if you look on the left side, if you compare patients who their invasive disease-free survival who are deemed high risk in the red curve, their outcomes were much worse than those patients in the non-high risk group. And then in the middle graphic, you can see those patients who had high risk based on their nodal status. Looking at, I know it's microscopic to look at, it's hard for me to see here, but the blue curve in the middle are patients who are non-high risk. And then in the red curve are those patients who are N1, then you've got N2, and then N3. So patients do much worse with nodal positivity. And then in those patients just who are node N1 disease that were high risk, that's what the HR stands for on the right-hand side, their invasive disease-free survival was much worse if they were high risk versus the N1 or the stage N1 low-risk subgroups in the blue curve. So you can still parse out patients who are high risk versus low risk based within those nodal groups. And patients who are higher risk have higher risk features based on grade, et cetera, that was used to determine a high risk group in Monarch E. Those patients do have worse outcome. There's also data that indicates from retrospective analysis of patients with stage 2 and 3 hormone receptor positive early breast cancer from the Concert AI Patient 360 database, looking at patients who are node negative and those who were versus those who are node positive. Their invasive disease-free survival is worse just by virtue of being node positive in the blue curve there. So when we are facing a patient, like the patient we presented initially, who has hormone receptor positive, HER2 negative early breast cancer, there's a number of features we all consider as we're assessing what treatment to recommend for them in the adjuvant setting. And so we're integrating clinical features and genomic features, as well as tumor-based features that help us assess a patient's risk. The stage and grade is really important. Our patient had a grade 3 tumor, which was discordant with that Oncotype score of 21. Tumor size, nodal status, patient's age and menopausal status, and then, of course, things like comorbidities that are competing factors for mortality have to be considered. So on this sort of dizzying graph, we'll just take through on the left side are the Monarch E eligibility criteria for adjuvant abemaciclib. On the right side are the NATALY eligibility criteria for adjuvant ribociclib. And what you can see with Monarch E is all patients had to have node-positive disease. So from the get-go, node-positive breast cancer in order to use abemaciclib. And the main criteria were patients with multiple nodes positives, or 4 or more positive nodes. Now, they did allow patients with 1 to 3 positive nodes, but they also had to have a larger tumor size, grade 3, or be in the smaller cohort 2, which was based on centrally tested Ki-67. NATALY, on the other hand, did allow patients with node-negative disease, and if you just follow the algorithm to stage 2A, node-negative, in order to be eligible, the patients had to have a tumor that was at least 2 centimeters in size and also have to be higher risk by virtue of either a Ki-67 of at least 20%, an Oncotype DX of at least 26, PAM50 high risk, Mammaprint high risk, or EndoPredict high risk scores. Grade 1 was not eligible for NATALY if it was node negative disease. Let's look at the Monarch E 5-year outcomes. We won't show you all the data for Monarch E. We're just kind of cutting to the chase to the more recent data. And what you can see, which we see all the time in endocrine-based studies for ER-positive breast cancer, is that a treatment that benefits patients in the adjuvant setting often has a carryover effect where you see the curves continue to separate over time, such that the delta at 3 years was only 4.8 percentage points in favor of abemaciclib. But by the time you get out to the 5-year mark, there's now a 7.6% absolute benefit in invasive disease-free survival by using 2 years of abemaciclib. Looking at these data in terms of distant relapse-free survival, you see a similar separation of the curve. Of course, it's lower numbers because patients often will have in-breast recurrences or contralateral recurrences that count for IDFS, but you're seeing a 6.7% difference in terms of distant relapse. That's what we care about, incurable relapses with the use of abemaciclib. Now, Natalie also has data. Now, Natalie enrolled later than Monarchy, so it's trailing in terms of the report outs. We don't have 5-year data, but at the 4-year data, again, you're seeing that similar separation of the curves over time. And at 4 years, that delta of 4.9% between the two arms in favor of 3 years of ribo is similar to what we saw with the Monarch E study. And distant disease-free survival is also similarly benefiting patients who received ribociclib. So how do we choose between these two agents? And we do this all the time in the clinic, I think. We have patients who are eligible for both ribociclib and abemaciclib. And as you probably struggled with that question, there isn't an absolutely correct answer. That patient had lymph node positive disease, and either of them would have been appropriate. Now, that patient was on a drug that could interfere with QTC, and so that plays into the choice. I think we have to look at side effect profile. Abemaciclib has a lower risk of neutropenia, a much higher risk of diarrhea. Ribociclib has a higher risk of ALT and AST elevation, as well as QTC prolongation, and we have to be vigilant by looking at our patients' concomitant medications and the yes, that one. The any drug that has QTC prolongation, you have to be really careful with. And then thromboembolic events with abemaciclib have to be taken into consideration as well. I would just mention one other thing. The starting dose of a ribociclib, or the dose of ribociclib for early breast cancer, is 400 milligrams daily, which is different from the metastatic setting where it's 600 milligrams. Now, studies have been done to look at dose modifications as well as dose holds for both abemaciclib and Monarch E and ribociclib and Natalie. And there were about 40% of patients who did have to have dose reduction, usually in the first few months with abemaciclib. And this is most likely owing to the rate due to diarrhea with abemaciclib. And there were patients who, about a third of them, who discontinued abemaciclib before the 2 years were up. About 20% were due to adverse events, mostly within the first 6 months of treatment. However, in spite of that, patients who did have dose reductions, including 2 dose reductions, do seem to have similar outcomes in terms of invasive disease-free survival. So if you have to dose reduce for a patient who's experiencing an adverse event with abemaciclib, you can reassure them that they're probably still getting the benefit by using abemaciclib. The TRADE study is an ongoing study. It's a phase 2 dose escalation trial looking at escalating, starting at a low dose of abemaciclib, starting at 50 milligrams twice a day, and then over a series of 2-week time periods escalating up. If you all remember the ExteNet study of neratinib and doing that dose escalation over 2 weeks to help with the diarrhea. So this is a similarly constructed study in the adjuvant setting with the primary endpoint of composite adverse event rate and discontinuation of adjuvant abemaciclib for any reason. love that we're having an oral abstract on something that's so clinically relevant to our patients. Erica Meyer is going to be presenting this. And it actually is a positive study. There was a release relating to this. And so I think this will be an interesting discussion that we can have in the clinic, especially for our frail patients who've struggled along the way with GI side effects. This might be considered doing a dose escalation strategy over the course of a month with abemaciclib to improve adherence to therapy. And in this study, they showed that over 90% of patients were continuing therapy at 12 weeks, which is better than we saw from the Monarchy study. So really intriguing data. Ribociclib has also been evaluated in terms of dose reductions and whether or not it affects efficacy, looking at a variety of time points here. Those patients who had dose reduction or did not seem to have similar invasive disease-free survivals. Now, another real-world study that I think is kind of shocking, and I had to look at this a couple of times, it's hard to believe, and it just underscores how important it is that we're aware of data and these tools that we have for high-risk disease. Despite the proven benefits that I've shown you in terms of distant relapse-free survival with these adjuvant CDK4/6 inhibitors, adjuvant abemaciclib utilization rates are less than 50%. There was a retrospective real-world study using the Flatiron database that looked at utilization over 250 U.S. institutions and showed that 60% of patients did not receive abemaciclib of patients who are eligible to receive it. Now, patients, over 2/3 of these had high-risk disease, 74% had grade 3 disease, and 70% of eligible patients who are 65 years or older did not receive abemaciclib. What, again, is very striking is race and ethnicity and how that relates to this, where Hispanic and Latino patients had the lowest utilization, 68% did not receive. But if you look at insurance type, socioeconomic status, and practice setting, academic versus community, that didn't weigh into receipt or non-receipt. So I think it's something we should all be aware of as we're encountering our patients in the clinic setting. And so now I think I turn it back to you for a discussion regarding our patient.
Yeah, thank you. Thank you, Sarah, for walking us through that lovely data. So let's get back to our case one again, right? So just as a refresher, this was our postmenopausal woman. She underwent upfront surgery, and that was a mastectomy with axillary dissection for a 4-centimeter tumor, 1 out of 3 positive lymph nodes, grade 3, invasive ductal carcinoma, oncotype of 21, and does take quetiapine for a bipolar disorder. And so our question here was, what kind of risk does she have and what treatment would you offer? So maybe I'll start asking you, Sarah, what would you do for this woman in your clinic?
Yeah, I think that it's really important, as I said, to take into account concomitant medications. And I would be worried about the QTC interaction and utilizing ribociclib. Although without that interaction, I think either of them would be appropriate to discuss because she had node-positive disease. The oncotype score is a little discordant. I mean, the majority of patients in Monarchy and Natalie received chemotherapy, and this is a patient who wasn't recommended to have chemo because she was over 60 and had a lower oncotype score. So this is one of those ones that she doesn't quite fit in that in that perfect eligibility. But I think she would be a good candidate, and probably I would recommend abemaciclib. And I'm just wondering if you would start using dose escalation because it's certainly attractive.
I think I would be tempted, I think. I mean, we learned that from the control trial for the rare patient we use neratinib for, right? I mean, the metastatic setting, I think at least we've tried using that for HER2 mutations. But for early stage patients, very rarely we will use for the right patient neratinib. But I think in that case, the control trial provided us that comfort that diarrhea can be managed better. So I feel like the TRADE study, I think, would be very helpful in that setting. I think when you were walking us through that data, that reminded me of that analysis that they had done in the elderly patients, where I think what we had realized was that patients discontinued. 1/3 of these patients discontinued without any dose reductions. And so this is a good opportunity for us to offer these therapies regardless of age, so that they can tolerate this better, maybe consider dose reductions if we had to, rather than discontinuation and derive the benefit. So I think I would. What about you, Dr. Cortez? Would you? No.
Well, I have not seen the data. I think that I want to wait and see what happens. I didn't realize about the trial was going to be presented this meeting, so I have not have time to relax, to look at the data. I cannot answer you now. So certainly if the patient would be frail with a lot of comorbidities, that's something that I would certainly consider. This is a patient about 60-year-old, 62, I think. This is not very old. I hope not, because I'm almost there. No, not yet. So no, I think that for this patient, I would not consider.
Yeah.
For frail, why not?
Yeah, no. And I think the question about the risk, I think, Sarah, as you were speaking, when we talk about intermediate risk, are we referring to the intermediate risk of recurrent score? Are we referring to the nodal disease burden? And how are we bucketing these patients into intermediate risk versus high risk? Maybe just walk us through, how do you think about them and how do you process this risk? And does chemotherapy make you that high risk patient? Is it N2 disease? How do you think about that?
Yeah, I think, grade is a little bit subjective. So pathologists can disagree on grade. And so I think the genomic scores have been sort of a nice way to do a central validated assessment of the biological features of the tumor and the aggressiveness. That said, this patient with a node positive and grade 3 disease, regardless of the oncotype score, would have been eligible for either of the studies. And, that oncotype score of 21, it isn't 11. There is a risk, and it was node positive disease. And we saw from that real world data, real risk of recurrences that continue to accumulate from years 5 to 10. And this is a fairly young person in her early 60s. So I think recommending a CDK4/6 inhibitor makes a lot of sense for this, even though there's discordant features.
Yeah. And then, do you think your recommendation would be any different if she was premenopausal?
It's a good question. I think I would be a little bit more concerned about interpreting the oncotype score in the face of nodal positivity. So I would have been a little more aggressive probably with the chemotherapy recommendation. But that's about it. I still would recommend a CDK4/6 inhibitor. What about you?
Yeah, I struggle with the same thing. I mean, if I have a patient walking into clinic with an oncotype result, that's a different scenario versus a premenopausal patient that was just diagnosed. And what I am trying to do, I think I'm still not necessarily, reaching out for oncotype. I think the RxPonder data, while does not address the question of ovarian suppression and chemotherapy, we have the offset trial that will address that in the coming years. It's going to take a while, I guess. But right now, I'm relying for these young women on chemotherapy, and I don't necessarily reach out for oncotype to try and avoid that unless the patient is super reluctant or it's a lobular cancer, and I'm really trying to figure out, okay, do I really need to offer that? What do you do, Dr. Cortez, in Spain?
Well, I think this is an interesting clinical case for different reasons. The first one is to consider high or intermediate risk. That's the first question. The second question is if this patient might benefit or not from chemotherapy. And the third one is if this patient might benefit or not from endocrine therapy plus abemaciclib in this case. So I would agree that, in my opinion, this is an intermediate risk patient. The reason is because, as you said before, I think grade 3 is something much more subjective than oncotype. And oncotype here is intermediate risk. So I would not offer chemotherapy based on the trial we have. But we should not forget, I think it was presented by Nick Turner, showing that in the Monarch E, the benefit of abemaciclib was the same regardless if the oncotype was of high risk or low risk. So I think that these patients benefited clearly from abemaciclib, but maybe not from chemotherapy.
Yeah. The RxPonder definitely for postmenopausal women gives us the confidence that we can avoid chemotherapy in postmenopausal women. The premenopausal women, I feel like that's a different scenario.
I don't know. I think that we have to wait and see what happened with the clinical trials about the LHRH agonist. But maybe today, this patient was grade 3. She has a very large tumor, 45 millimeters. If premenopausal, what does premenopausal mean? It is a 50-year-old, almost there, or I would consider chemotherapy nevertheless.
So 2 interesting online questions that maybe we can cover as well. That would you send an oncotype on a large tumor that was N1? so larger than what has been studied, I think, in trials. That's one. And the second question along the same lines, what else do you rely on for a decision about chemotherapy outside of oncotype?
So yes, I would send an oncotype on larger tumors. I think more and more we're seeing size doesn't matter in oncology. It's the biology, and I think oncotype gets at that. In terms of other factors, I think we've listed them. Age, comorbidities, menopausal status weighs in, features like that. Progesterone receptor expression, Ki67, which isn't done everywhere, but you can utilize it as a tool if it is done.
Yeah. And then maybe before we move on to the next question, and we'll do more questions at the Q&A session in the end as well, maybe any strategies that you utilize in clinic for AE management that you want to highlight and share with us, and maybe also compliance and adherence. If you had a patient who was either reluctant or did not fill their prescription or did not necessarily show up to their follow-up appointment, how do you tackle these two issues?
It's really important. I think we have to use our APP partners in the clinic and nurses in the clinic. Pharmacists can be very helpful connecting with patients, especially the first month they're on therapy. Now, all of our patients on CDK4/6 inhibitors are coming in every 2 weeks for labs and sometimes EKGs in the first month or so. And so that helps us with it. But I think the dose escalation strategy is great for the patient you mentioned, somebody who's reticent to take pills at all. This is a great strategy because it's like, we're just going to give you a little flavor of it and see how you do with it and go slowly. And patients love that.
Yeah, no, I think that's a fantastic reminder. Okay, great discussion. I think we'll come back to this a little bit again in the end as well, but let's move on to the next section. Okay, moving on to module 2 then. We'll move on to metastatic breast cancer and talk about guiding precision amid growing complexity, making multifactorial clinical decisions for hormone receptor positive metastatic breast cancer. So let's start with our second case. This is a 61-year-old postmenopausal woman. Breast imaging confirmed a 3-centimeter mass and enlarged axillary lymph nodes, underwent upfront lumpectomy with adjuvant chemotherapy and radiation followed by adjuvant aromatase inhibitor, completed 5 years of aromatase inhibitor therapy, and 1 year after completing the AI developed right hip pain. Bone scan at that time showed lytic bone lesions. A CT chest, abdomen, pelvis showed numerous liver and bone metastases involving the spine, hip, and ribs. Liver biopsy was done, which showed ER-positive, PR-negative, HER2-negative carcinoma consistent with her breast primary. ctDNA testing was done at that time with no ESR1 mutations or PIK3CA AKT-PTEN alterations. Germline testing for BRCA1 and 2 is negative. Liver function studies are normal. Comorbidities and medications include ventricular tachycardia, treated with disopyramide, and baseline EKG showed a QTc of 445 milliseconds. And before we just get into this meaty discussion, I think one thing that I'd like to probably discuss with all of you is the importance and how are we thinking about incorporating biomarker testing for patients with hormone receptor positive breast cancer. Current guidelines recommend that treatment choices can be informed by prior treatments and routine testing for activating mutations, may it be ESR1, PIK3CA, AKT, or PTEN. But the questions that come to mind are, when do we test? Do we test at baseline when a patient is diagnosed? Do we test upon progression? What test do we reach out for? Should everybody get tissue NGS testing? Should we get liquid assays for everybody and not do tissue testing? How do we educate our patients about the importance of biomarker testing? And talking about patients, one good, community-led campaign has been No One Missed. This is a metastatic breast cancer campaign, which is focused on, and it's launched in partnership with our partners, Living Beyond Breast Cancer, with a mission to build public awareness or patient awareness for biomarker testing and empower the patients to know, to ask their team, their clinical caretaking team, about biomarker testing and what does that mean and what implications would that bring. And so there are downloadable materials for biomarker testing tools that they have created for patients so that they're aware and can discuss that with their team. So maybe I'll take a pause here, and maybe Dr. Cortez, you could talk about your practice patterns about when do you think about testing, what testing do you reach out for, and how do you educate patients about biomarkers?
Well, I think this is a question that we can be here for all the evening and we will not have a definite answer. So my first comment here is don't do something if the results will not help you to treat your patients. Why am I saying this? Because I'm coming from Spain. You are coming from the United States. You have inavolisib in the first line setting. I do not have that. So why do I need to know the PI3CA status in the first line setting if I am unable to give any treatment for my patients based on that decision? So I think that if we can do something based on that, do it. If not, I would be against doing it because this could be very, I would say, dangerous for the patient because they will have some interest in some drugs that it will not be available. If you have clinical trials, that's another story. Having said that, I think that if you have PIK3CA, I think that PIK3CA is something that you have to do upfront. But ESR1, we all know that this is something that might be acquired, so it does not make a lot of sense maybe to do it upfront. So we have to take into account what is the biomarker we need, and depending on that, I would require maybe liquid biopsy or tissue.
Yeah, and maybe in contrast, you want to share in the United States, now that we have that approval, how do you approach testing?
Yeah, so the approval for inavolisib is fairly strict. You have to have had your disease recur while on or within 12 months of AI. So our patient is right there. Let's assume it's 11 months and something. And the patients, there were pretty strict entry criteria for the HbA1c and fasting plasma glucose. So if you have a patient who is not going to be eligible to use inavolisib, then why send the next-gen sequencing in the first line? I would wait until the second line when we're going to need to do it again to look for ESR1 mutations, which accumulate and are acquired over time. So I think you look at the patient, if they'd be a candidate for inavolisib, I would send it in the first-line setting.
Yeah, so completely agree. I do the same. If there is a patient that fits the NAVO 120 trial criteria, I would think about utilizing them. We also have metastatic tissue available at that time that could be cooking, but I don't mind sending even a ctDNA assay with a faster turnaround time for such a scenario, for such a case in clinic. But otherwise, I think at the very minimum, outside of that, immediately post first-line therapy progression, because that's when we want to think about treatment assignments based on ESR1 mutation status, PIK3CA mutation status, or AKT mutation status, or even PARP inhibitors for germline testing. So certainly we want to use that. And I think ESR1 being subclonal mutations, we think about ctDNA way more. I think tissue prevalence is about 20%, but if you think about plasma in the second or third line is 40 to 50%. PIK3CA could be done by both, while gold standard is tissue, and rarely you will see a ctDNA maybe not showing that positivity. And so you could think about reflexing at the tissue, but otherwise you could use either or. PTEN, on contrast, is better in tissue. You can miss loss of PTEN on ctDNA assays. So there are some nuances that we have to keep in mind when we're thinking about, have we done it all to make sure we're not missing an opportunity to offer a therapy for a patient. Okay, with that in mind, I'll hand it over to Dr. Cortes to walk us first-line therapy options for hormone receptor-positive metastatic disease.
So, thank you, Kamal. So let me start with this slide. I was a little bit surprised about the questionnaire we have before. 0% of our folks here voted for palbociclib-based therapy. 0%. It's interesting. I will make some comments in a minute. So how do we foresee the treatment of ER-positive, HER2-negative metastatic breast cancer? I think that we all agree that CDK4/6 inhibitor-based treatment is the optimal approach, with or without inavolisib, based on the issues you commented before. So these are the trials we have, very well known by all of us. This is not to look at the median PFS across different strategies, because there are patients treated in the first line, the second line, in both lines. The point is that in all trials, the benefit of CDK4/6 inhibitors were exactly the same. The hazard ratio was very consistent in the range of 0.50. So my first question, I know that we do not have survival benefit from palbociclib. I do agree. But we do not have survival benefit for many drugs. And why do we have to talk about survival now when all these trials were designed for progression-free survival? I'm not saying yes or no. What I'm saying is that also palbociclib has some benefits. For example, drug-to-drug interaction for some frail patients So I think that there are patients for all of them, but also for palbociclib. That's my opinion. Again, absolutely happy to discuss afterwards if needed. This is the overall survival data. Again, here, it is not to compare. It is true that both trials with palbociclib did not achieve overall survival improvements. Again, there are many aspects that might explain these results, but data are the data, and it is what it is. Now, this is the INAVO 120. I think that Kamal summarized in 2 minutes. She was the PI with Nick Turner of this trial. Just remember, patients should have had endocrine-resistant tumors, and this is key. These are very bad prognostic patient population for 2 reasons. The first one is because all patients did have resistance to endocrine treatment, and the second, all patients did have mutations in PIK3CA. Primary endpoint was progression-free survival, and patients were randomized to receive fulvestrant, palbociclib, plus inavolisib, or placebo. Remember, inavolisib, the dose, 9 milligrams a day. Here we have the extraordinary results. These results will be updated tomorrow, okay, also with the overall survival. You can see here the hazard ratio, 0.43, and the median moved from 7.3 months to 15 months. I think that clear, and standard of care in this patient population with very bad prognostic features. Now, overall survival, there was a clear trend at that time. We know by the press release, again, it will be presented tomorrow by Nick Turner, showing the positivity also in terms of overall survival. This is the press, well, this is not the press release. These are the key endpoints regarding the overall survival. Hazard ratio 0.67 in favor of inavolisib, moving from 27 months. Look at the median overall survival. First line, ER positive, 27 months. This is it's a little bit better than triple negative, but not that far. 27 months compared with 34 months. Again, this is a clear unmet need, very bad prognostic patient population. The median progression-free survival moved to 17.2 months in this updated analysis. Now, what about adverse events? In my opinion, adverse events were much better compared with alpelisib. Look at here, basically, stomatitis in the range of 50% of patients, being grade 3 in the range of 6%, 5.6%, hyperglycemia in the range of 60% roughly, grade 3 in the range of 5.6% again, and diarrhea in the range of 50%, being grade 3 for 3.7%. Now, just to remind us that we have a second randomized phase 3 trial ongoing, which is INAVO 123. This is for patients with PIK3CA mutations, but sensitivity for endocrine treatment, which means that or de novo tumors or patients who received endocrine treatment and the treatment-free interval was more than a year. So this clearly complements INAVO 120. This is an ongoing clinical study. And patients were randomized to receive letrozole. I think the trial is going to be amended. Letrozole plus CDK4/6 inhibitor, whatever CDK4/6 inhibitor is, with or without inavolisib. So I go back to the clinical case.
Yeah, so let's go back to this case again. So quick refresher, this patient had upfront surgery, adjuvant chemoradiation, and AI, and 1 year after completing AI, developed hip pain, had liver metastases and liver biopsy, did confirm ER positive, PR negative, HER2 negative breast cancer, no alterations, no germline mutations, is on disopyramide for ventricular tachycardia with a QTc of 445. And the question was, how would you treat this patient and what treatment would you recommend for this patient? And which factors would you be considering in determining the first-line therapy for her? What if biomarker testing had shown a PIK3CA mutation? That was the case too that we were talking about. So maybe, Javier, walk us through what you would do for this patient in clinic. I know you mentioned a little bit about what therapies are available and how would you think about it, but for this particular case, how would you approach it? What would you do?
Well, first of all, I would feel comfortable with all CDK4/6 inhibitors. We have to discuss. I think tachycardia is not something very important, in my opinion, to decide the CDK4/6 inhibitor. The QTc prolongation is not very frequent with ribociclib. I feel comfortable with all of them. To be honest, maybe in this case, again, she had tachycardia. I would prefer abemaciclib. That's what I would choose, but I feel comfortable with all of them. Clearly, if the PIK3CA mutation would be there, I would go for fulvestrant, palbociclib, and inavolisib.
I think the points Javier has made about palbo, I think it's not arguable. It's the best tolerated, right? Patients feel well on it. They can be on it for many years. With ribo and abema, there's a lot of management that we have to do for side effects. You can't get around there was no benefit in the early stage setting with palbo. That, with the lack of survival benefit, it's like you're explaining the data away a lot. I think probably the potency of the other two, there may be a long-term benefit to the other two but I think palbo is a reasonable approach in the metastatic setting, and I think it's really well tolerated. Abema is harder. Patients have rumbly tummies. They don't feel great. They have, even if the diarrhea is controlled, they will have these episodes of unpredictable diarrhea that makes work difficult. So I think there's just a lot more hand-holding long-term in my own experience. And then ribociclib, we have to be careful. So I think this is shared decision-making, right? We have to talk to our patients.
There is something funny here. So in the first voting, everybody, or the majority, decided from AI plus either ribo or abema, okay? However, if the PIK3CA mutation existed, everybody, 50% of us, decided for fulvestrant plus palbo for inavo. So if this patient qualifies for inavo 120, why would you decide to go for AI plus CDK and not fulvestrant plus CDK? Do you see my point? So it's interesting to see.
But I'll do fulvestrant plus CDK based on the Mona Lisa 3 study.
I would agree.
Yeah,
I agree.
I do.
So these are 11 months, I think.
Yeah.
1 year after, so 12 months. Same benefits.
But my point is, if it qualifies for inavo, then without mutation, should be fulvestrant. If you decide AI, then it would not qualify for inavo. You know what I mean?
Right.
So
right. No, it's an excellent point. I think the point you're making is that if you're thinking about endocrine sensitive disease, then you're very comfortably choosing AI. If you're thinking resistant, then you should be thinking fulvestrant. Or for sensitive, based on Mona Lisa 3, could justify fulvestrant. Although in such cases, I still keep fulvestrant at the back end, just because what do I do after? So I keep fulvestrant for that. But yeah, no, I think it's a distinction. You have to make that commitment of how you're thinking about this case and whether it's an endocrine resistant tumor and you want to go with fulvestrant backbone or not. So excellent point. And a quick word on biomarker testing again. I think it's the same that you said. If a patient fits a criteria for a clinical trial or for inavo 120 regimen, I think it's imperative that we test for the mutation and do that testing upfront. If not, I think it's okay not to necessarily look for anything, get the patient started on a CDK4/6 inhibitor, and certainly consider that at the time of progression. So I think that point is very clear here. Okay, so let's do another case. We have a patient who's, again, 61. I think we have a lot of 61-year-old postmenopausals today. But 61-year-old, ER-positive, HER2-negative metastatic breast cancer, had first-line palbociclib and AI.
There you go.
There you go.
Got a palbo.
This was definitely a patient from Spain, I guess. But after 18 months, developed asymptomatic progression in bone and new liver lesions. And ctDNA testing revealed presence of ESR1 mutations, but no PIK3CA, AKT, PTEN alterations, no germline BRCA mutations. All right, Dr. Cortes, maybe you can talk to us about second-line therapy.
Sure. Okay, what to do after CDK4/6 inhibitors? We have different options. Here, I think that it depends on, first, what the patient used before. Second, I think that here, the different mutations or alterations might be important. We have to take into account PIK3CA, AKT, PTEN, but also ESR mutations to decide, again, if we have the possibility to have all these different agents. We also have fulvestrant monotherapy, fulvestrant plus different CDK4/6 inhibitors. So we have different options. How to decide which is the best approach to treat our patients? So this is the post-MONARCH. This is the only randomized phase 3 study which wanted to explore if CDK4/6 inhibitors work after CDK4/6 based therapy. This is a fulvestrant placebo or fulvestrant abema. Patients should have previously received any CDK4/6 inhibitor plus endocrine therapy, but not other treatments in advanced breast cancer. Also, CDK4/6 inhibitors could have been used in the adjuvant setting if the disease recurrence happened during or just after the CDK4/6 inhibitor. Primary endpoint, investigator-assessed progression-free survival. Here we have the data. Hazard ratio was 73 in favor of abemaciclib, moving from 5.3 to 6 months. It's a small, medium improvement, but it's true that when we looked at the BICRA analysis, it was much more superior. So there was a clear benefit of continuing with CDK with abemaciclib after palbo, ribo, or abema.
Okay. And then maybe I'll walk you through some other second-line options as well. So talking about oral SERDs, and we now have approval for elacestrant for ESR1 mutant tumors and some data that we now have from EMBER-3 that I can walk you through as well. So talking about ESR1 mutations, they occur under the selective pressure of aromatase inhibitors in the metastatic setting. And really, in this evolution, we see these mutations which lead to ligand-independent but ER-dependent growth of the tumors. And when we think about our existing therapies before we had oral SERDs, while they are effective, we know that after a certain time on those therapies, patients' tumor do develop progression or recurrence. And certainly in addition to that, we have seen toxicity challenges with these drugs, aromatase inhibitors and tamoxifen. And fulvestrant has challenges beyond toxicity, I guess, which is just the injection discomfort. But it has a PK liabilities in that there's lack of oral bioavailability. The dose cannot go up beyond the 500 milligram dose. We've seen very modest activity for single-agent fulvestrant post-CDK4/6, and activity certainly is limited for certain ESR1 mutations, which is why multiple novel endocrine therapies are being developed, and many are in phase 3s already, whether it's novel SERMs, whether we're talking about proteolysis targeting chimera, or PROTACs, or we're talking about complete estrogen receptor antagonists or CERANs. The idea being we want to just optimize the therapeutic window, the therapeutic index and efficacy, and certainly want to overcome the toxicity issues, the PK liabilities, and improve upon what we currently have in clinic. So the one that has made it to the finish line is elacestrant based on the phase 3 EMERALD trial that is summarized here. So these were metastatic breast cancer ER-positive patients, no more than 2 lines of endocrine therapy, no more than 1 line of chemotherapy, patients randomized to elacestrant 400 milligrams versus physician choice endocrine therapy. For primary endpoint, looking at PFS in all patients and PFS in ESR1 mutant tumors. When we look at what proportion of patients had visceral metastases, more than 2/3 had visceral metastases on this study. About 55% had 1 line of prior endocrine therapy. 1/3 of these patients had already had prior fulvestrant, and approximately 20% had 1 line of chemotherapy before they were enrolled on this trial. And here are the Kaplan-Meier curves. On your left is PFS for all patients. On your right is ESR1 mutant tumors. And what you see is while you see the benefit for elacestrant over physician choice endocrine therapy, the benefit is better the curves are separating more in the ESR1 mutant tumors. The benefit there translates to a hazard ratio of 0.5. And as such, currently the approval is limited to the ESR1 mutant tumors with monotherapy elacestrant in clinic. What about overall survival? These data were rather immature at that time, and we need longer follow-up and more maturity to be able to claim significance for such data sets. Several other agents have been attempted with monotherapy comparisons as well. So EMERALD, we spoke about, is a positive study. SERENA-2 is a phase 2 trial with camizestrant, head-to-head comparison with fulvestrant and fulvestrant-naive patients. Again, that study met its primary endpoint. In contrast, AMEERA and ACCELERA with amcenestrant, that is no longer in development, and giredestrant, that remains in development, were negative. But the idea here is not to cross-trial compare. These were very different patient populations, very different treatments that they had received before enrollment, not necessarily powered for ESR1 mutants in all trials equally. But a common signal that we saw across all these trials was numerically, if it was a negative study, the benefit was still larger in ESR1 mutant tumors. We recently also saw data from the EMBER-3 trial. This trial really focused on predominantly a second-line patient population. These were patients who either recurred on or within 12 months of their adjuvant aromatase inhibitor with or without a CDK, or first-line metastatic aromatase inhibitor with or without CDK. No other therapy for advanced metastatic disease, no chemotherapy. 874 patients randomized to one of the three arms, imlunestrant alone, physician choice endocrine therapy, and in an amendment, a third arm was added early on in the trial, which evaluated imlunestrant plus abemaciclib to see if that would be an efficacious therapy. And there were three primary endpoints because of that. One was to look at monotherapy comparison in all patients, monotherapy comparisons in ESR1 mutants, and then last, looking at the doublet of imlunestrant abema with comparison to imlunestrant alone in all patients. Patient characteristics summarized here. Nearly 40% had ESR1 mutations at baseline, approximately 40% with PIK3CA alterations. This could be PI3K, AKTP10 at baseline. Most recent endocrine therapy, majority were in the advanced. So 2/3 had received endocrine therapy for advanced breast cancer, a third with adjuvant disease. Approximately 60% had received prior CDK, so 40% were CDK4/6 naive. In the doublet arm specifically, 65% had prior CDK. 2/3 of that CDK being palbociclib, a third being ribociclib, and a very small proportion, understandably, being abemaciclib. Here are the results for the ESR1 mutant monotherapy cohort comparison. Significance favoring imlunestrant, improvement from 3.8 to 5.5 for median PFS, hazard ratio of 0.62, which is statistically significant. We then have imlunestrant versus standard of care endocrine therapy for all patients, so intent to treat patient population. Here we did not achieve statistical significance. The hazard ratio is 0.87. And interestingly, the majority of the subgroup, we said 40% were ESR1 mutants, so 60% that were ESR1 not detected, showed no difference in PFS. The hazard ratio was actually 1. So it's not inferior, but definitely did not show statistical significance. Because one of these was positive, the trial then looked at comparing the doublet with imlunestrant alone, and surely enough with the doublet, we see a median PFS of 9.4 months compared to 5.5 months. Hazard ratio here is 0.57, which was statistically significant. Now, these were subgroup analyses. We said monotherapy was active only in ESR1 mutant tumors. What about doublets? So consistent benefit was seen for the doublet, both in ESR1 mutants and ESR1 not detected tumors. On your left are the Kaplan-Meier curves for ESR1 mutant tumors, where the median PFS for the doublet is 11.1 months. On your right is those without ESR1 mutations, where the median PFS is 9.1 months. Now, certainly what we currently do in practice is CDK4/6 inhibitor in the first line. So it was very important to look at how does this doublet fare for patients who already progress on a CDK4/6, and consistent benefit was seen in that group as well. Again, 65% had prior CDK in the first line. And in this group of patients, the median PFS for imlunestrant abema was 9.1 months. Similarly, we have PI3K pathway approved drugs. What do we see with the doublet for pathway altered patients? So PI3K pathway altered patients, here the median PFS is 7.6 months. The imlunestrant alone arm here is 3.8 months. These are subgroup analyses that were seen looking at the imlunestrant combination with imlunestrant alone. Again, you see all the subgroups are kind of favoring the doublet. Everything seems to be on the left favoring, regardless of ESR1, PI3K, concurrent mutations, prior CDK type in any setting, or patients previously treated with CDK or not. Subgroup analyses were presented actually by Christina Sara at the ESMO Breast meeting. And so this was, again, to look at what we just discussed, PFS in all patients with CDK4/6 pretreatment. So overall, it was 9.4 months. In the pretreated patient population on your right, it's 9.1 months. And then talking about safety, obviously, I think very important for us to know what we're dealing with in clinic. Majority of these patients had low-grade toxicities of fatigue, diarrhea, and nausea. So 23, 21, and 17%. These were predominantly grade 1 toxicities, mostly single episodes. Grade 3 or higher toxicities in the imlunestrant alone arm were 17% compared to 21% in the physician choice endocrine therapy arm. Low rates of discontinuation at 4% with imlunestrant alone. Certainly with ABEMA, we've been talking that diarrhea is a most important signal. We see some low-grade diarrhea with imlunestrant. So the question was, will adding those two increase the amount of diarrhea? Certainly there was more diarrhea reported. However, again, this was grade 1. And discontinuation rates remained low at 6.8%. There were no PK-PK interactions. And the safety profile is similar to what we've seen with Monarch 2 with fulvestrant ABEMA as well. So it's not that adding abemaciclib to imlunestrant led to very worse disease. And as I said, discontinuation rates remained low at 6%. So what is being presented at this meeting, I think it'll be important to see the patient-reported outcome. So Giuseppe Corigliano will be presenting that at the oral metastatic session. So important to keep an eye on that. And certainly we will also hear from the PROTAC, the monotherapy data from the phase 3 VERITAC-2 trial. Erica Hamilton will be presenting it at the same session. So certainly keep a lookout for these presentations at this meeting. Beyond the CDK4/6 combinations, I think we're excited about other combinations, such as agents targeting the PI3K-AKT pathway as well. So on your top left is the ADELA trial, predominantly run in Europe and Brazil. This is looking at LSS-strand plus everolimus versus LSS-strand alone in ESR1 mutant tumors. On your right corner, at the bottom, you have the IVERA trial. We hope to hear results from this phase 3 trial maybe by the end of the year. This is looking at giredestrant plus everolimus versus physician choice endocrine therapy plus everolimus. We certainly have Pionera. This is another CDK4/6 combination with giredestrant. Pionera is for patients who would recur on or within 12 months of endocrine therapy. So this is giredestrant CDK versus fulvestrant CDK. And in this case, it could be any CDK. It could be palbo, ribo, or ABEMA. Elevate is an umbrella trial with LSS-strand looking at multiple combinations, and there are going to be additional data that are going to be presented at this meeting as well from the study, including LSS-strand plus ribo and LSS-strand plus everolimus cohort. So keep a lookout for that as well. We're not only seeing this monotherapy effort, this combination effort. We saw some EMBER-3. We saw these trials that are currently ongoing. We're also trying to wait to see if we use oral SERD and CDK in the first line, will we further move the bar from the 28-month PFS that we've been able to achieve with the ICDK? And that's the effort behind Persevera and Serena-4, looking at giredestrant and camizestrant, respectively, with a CDK, comparing it to an AI-CDK combination in the first-line metastatic setting. And what is going to be also presented at the plenary session this year that we should all catch is the Serena-6 trial. And this is similar to the PARA-1 in that should we be making a switch in therapy with the first instance of ESR1 detection. So these are patients who start on AI-CDK. We serially start collecting and following their ctDNA. And if you see an emergence of an ESR1 mutation, should you then randomize them, in this case, to camizestrant and continue the same CDK versus standard of care that you would continue the same AI-CDK that they were already on. And Nick Turner will be presenting that on Sunday at the plenary. So many strategies that we're trying to figure out what the most optimal way of doing it. What do patients think about that and what are their preferences? I think this is really, really important as well. We keep saying that it's really important for us to have so many discussions with our patients about a patient-physician shared decision-making process. It'll be very interesting to see what their perspective on Serena-6 would be, for instance, or an approach like EMBER-3 or an approach like Serena-4 and Persevera as well. But multiple factors go into play, and accumulating evidence really suggests that patients prefer oral drugs to IV drugs. Why wouldn't they, right? It's good quality of choice. And so that's why we remain excited about these novel endocrine therapies as well. It's more convenient. Certainly, you don't have to come into the centers to get your injections, anxiety about injections, discomfort from injections. And that's why the PRO data are going to be important as well. Let's cover the other options targeting the PI3K-AKT-mTOR pathway as well.
So, very quickly in the last maybe 6 to 7 minutes. So what happens when the resistance is not only driven by the estrogen receptor, but also because of many other signaling pathways, basically the PIK3CA, AKT-mTOR signaling pathway. And here we have different strategies. We have alpelisib, we have Capiva, we have everolimus, and we have in the future inavolisib probably. So how to move forward? Oh, you all know that this is a very important therapeutic target. This is a pathway that might be active and is involved as a mechanism of resistance, not only to endocrine treatment, but also to anti-HER2 therapies and also to chemotherapy. And there are different ways to activate this pathway by different membrane receptors, by mutations in different genes, but also breaking the brake of this inland pathway, which is PTEN, among others. So this is Capitolo 291. Just remember, this is a randomized phase 3 study of fulvestrant Capiva or fulvestrant placebo. Remember, Capiva dose 400 BID, 4 days on, 3 days off. It's quite unusual for at least in the field of breast cancer. Patients could have received up to 2 prior lines of endocrine treatment and a maximum of 1 line of chemotherapy in a metastatic disease. Primary endpoint progression-free survival in the overall population and in patients with the AKT pathway altered, which means PTEN alteration, AKT mutations, and or PIK3CA mutations. Here you have the key results in the overall population. Has a ratio of 0.60 in favor of Capiva, moving from 3.6 to 7.2 months. This is where the drug has been approved, basically in patients whose tumors do have the pathway, the AKT pathway altered. And you can see here the hazard ratio was 0.50, very similar features in terms of the median PFS for both placebo, 3.1 months, or Capiva, 7.3 months. What about SOLAR-1? SOLAR-1 is the pivotal trial with alpelisib, a PIK3CA inhibitor. Here we have the progression-free survival in patients with mutation in the PIK3CA. Again, a positive study, basically in patients with mutations in the PIK3CA. Hazard ratio here, more or less, in the range of 0.65. Now, BELIEF. BELIEF is a very important study because these are phase 2 study with 3 different cohorts, but this trial explored the role of alpelisib plus or fulvestrant or aromatase inhibitors in patients who received previous treatment with CDK4 and 6 inhibitors. Remember, in SOLAR-1, patients did not have received CDK4 and 6 inhibitors. Here we have a median PFS in the range of 7.2 months, more or less. What about everolimus in the era of CDK4 and 6 inhibitors? Of course, Bolero-2 was a very old study. No patients received CDK4 and 6 inhibitors. That's why we had this phase 2 single cohort, about 50 patients treated with fulvestrant plus everolimus in CDK4 and 6 inhibitor pretreated tumors. You can see here the median PFS in the range of 7 months, 6.8 months, and overall survival in the range of 38 months. And this is very interesting to observe that the data was very similar regardless the duration of the previous CDK4 and 6 inhibitors. It's only 50 patients. So at the end, it's about 25 more or less. Now, what's coming next? We have 2 important randomized phase 3 studies. Victoria-1, which is quite complex. It has 2 different cohorts. One of them, the PIK3CA wild type, and the second one, the PIK3CA mutant cohort. This gedatolisib is a dual mTOR PIK3CA inhibitor, and you can see here that this has 3 different arms. So depending on the cohorts, or fulvestrant plus HEDA, fulvestrant plus HEDA, and palbociclib in the PIK3CA wild type, in the PIK3CA mutant, fulvestrant alpelisib, fulvestrant HEDA, and the triple combination. And the second study is in AVO 121. This is a face-to-face fulvestrant alpelisib, fulvestrant inavolisib. Well, back to you.
All right, let's go back to our case again. So 61-year-old, postmenopausal, received first-line therapy for 18 months with AI-CDK, and then upon progression, ctDNA showed an ESR1 mutation, no PI3K alteration, no germline mutation. So what would you do, Dr. Cortes, if you were given a choice? Would you do doublet? Would you do monotherapy? And if you had all options available, which monotherapy or which doublet?
So for me, it's important to consider the progression-free survival with a CDK4 and 6 inhibitor. For me, the 12 months is something critical. So lower than 12 months, I would consider the oral SERDs or not. For more than 12 months, certainly that's something I would consider. So the key question here is elacestrant, in my opinion, imlunestrant or imlunestrant plus abemaciclib. I think that all of them are good options, all of them. We have with elacestrant a median progression-free survival in this patient population in the range of 8.6 months, which I think is not bad at all with single agent. With imlunestrant, we do not have this specific data, but I think it will be very similar. And maybe combining with abemaciclib, we could increase this data. So I would like to discuss with the patient, elacestrant single agent could be a very good option here. Maybe imlunestrant plus abemaciclib could be even better for selected patients.
Makes sense. So it would be a patient-physician decision-making process, an individual patient decision. What if your biomarker testing had PIK3CA, AKT, or PTEN instead?
Me. Okay, so...
You again.
So for me, the mutations in the PIK3CA pathway are drivers if these explain the resistance early on time. What do I mean? If this patient was on treatment for more than a year, so 18 months, in my opinion, maybe the PIK3CA is not playing a significant role here. Maybe the acquired resistance could be, again, in my opinion, could be playing a major role. That's why if more than a year, I would consider oral SERDs as my first option. If less than a year, certainly I would consider PIK3CA inhibitors.
Gotcha. And if you had both ESR1 and PIK3CA mutations?
That's what I'm referring. So here,
Yeah.
ESR1 will be the driver, in my opinion. If less than a year, I would consider the PIK3CA pathway.
Okay. And so it's not visceral disease burden or anything like that. Does that?
Yeah, of course, it is not black or white. So of course we have to take into account many other aspects. But I would love to combine the oral SERDs with the PIK3CA inhibitors. For example, the Adela is exploring this strategy.
So we'll have more data with maybe novel combinations or novel oral SERD combinations with the PI3K pathway drug, which would be the ideal choice. So hopefully in the future we won't be discussing this question differently. But for now, it's a patient-physician decision-making process. And then moving on again, so this is the third line and beyond setting. We have options that, either if the tumor is endocrine refractory, we move on to sequential single-agent chemotherapy. We have antibody drug conjugates approved. In fact, we have true TROP2 ADCs, not just sacituzumab. We have datopotamab approved as well. We have T-DXd for HER2-low tumors. But let's go to our Q&A. We have multiple questions. Maybe we'll just do a rapid fire and get through all of them, right? Quick, short answers and just move on to all the questions so that we can get to all of them. So first one, maybe Sarah, for you, for early stage, do you use MammaPrint? And if a MammaPrint result came back as high risk 1 and you did not have an oncotype, how do you approach treatment decision?
I tend to use Oncotype preferentially because it's got prospective validated information that it provides. But if a patient comes to me with MammaPrint and it's high risk, I will utilize that and won't test Oncotype on those patients.
Do you use MammaPrint?
We don't use it a lot, but we do. But I feel comfortable with both of them.
Okay. And between MammaPrint 1 and 2, any differences in treatment choices maybe?
Again, these are discussions with the patients. It's new.
Fair enough. Fair enough. How much limiting issue is polypharmacy in our practice, and how does that influence our adjuvant CDK4/6 inhibitor selection? I think we discussed that a little bit briefly. We do have to rely on that, comorbidities, medications, side effect profile, and make the decisions. We had the patient with quetiapine where we did not tend to choose ribociclib. So I feel like, yes, polypharmacy does play a role. What about oral SERDs in the early stage setting? You want to comment on what do you think about that approach and maybe tell us a couple of trials in that space?
Yeah, there are a number of trials ongoing in the early stage setting. I couldn't list them all off right now, but giredestrant is being looked at in the lidERA study. Maybe each of us could list one here.
Yeah.
We will have data. And I think the question becomes, how are these drugs going to work? Because the de novo presence of an ESR1 mutation is only about 1% of patients. So what we're doing is delaying the acquisition or the selection for these mutations. So we're going to have to wait a long time maybe to see these benefits. The switching trials are going to be interesting to see.
Yeah. I think that Cambria 1, Elegant, and and EMBER-4, the sequential ones are the most interesting in my opinion.
Yeah. No, I think it's a very interesting puzzle to have because in the metastatic setting, we keep showing all the data where we are seeing positive signals only in ESR1 mutant disease. And we keep saying that these are acquired in the metastatic setting and not in the early stage setting. The way I think about them is that ultimately these are endocrine therapies, right? They should work for endocrine wild type and they should work for endocrine resistant tumors or ESR1 mutant tumors. I think the biology is way more complex in the metastatic setting and heterogeneity is way more. It's a little more simpler in early stage breast cancer. And so hopefully there we're not necessarily only relying on ESR1 mutations to drive the benefit from these drugs. And hopefully we can just still show the benefit in early stage regardless of ESR1 mutation. We saw that with AI and tamoxifen. Hazard ratios were really high, but AI is our standard of care for postmenopausal women with hazard ratios of 0.8 without any OS benefit. So I'm hoping that with a better toxicity profile with these drugs, we might be able to do that. But I agree, I like the switch strategy myself as well. So it'll be interesting to see what upfront strategies show, what upfront with CDK in Cambria 2 will show, or what a switch strategy in Cambria 1 and EMBER-4 will show. So a lot of excitement there. Question about, can we start lower dose of CDK in the adjuvant setting, for example, for older patients? I'd say
The trade study will have some data.
Yeah.
Check it out a couple days from now, and
Yeah.
you be the decider. But I think it's perfectly appropriate in select patients.
Yes, as George Sledge taught us, you can only derive benefit if you take a drug. So some drug is going to be better than no drug, and Dr. Hurwitz walked us through the data that the efficacy was not compromised if you did dose reduction. So I think it's appropriate for an older patient to start with a lower dose. We touched upon combination therapy versus single agent therapy. I'm assuming the question is referring to oral SERD. I think we said both might be appropriate depending on the scenario. The data looks good with EMBER-3 for the combination as well. Is it appropriate for everybody? Maybe not. There might be some patients where monotherapy still remains appropriate. We get challenged with identifying them very easily. Right now, we rely on duration of CDK and ESR1 mutation, obviously, but that's not necessarily as simple as it sounds, and there might be more nuances, but those are the patients we would still be okay with monotherapy. What is the status for giredestrant, Evera, and Persevera? Great question. I think both studies were eagerly awaiting results. I'm hearing that maybe Evera will hear by the end of the year, Persevera soon after. So very soon we will learn a little bit more about other combinations, both first line and with everolimus. Can any CDK4/6 inhibitor be considered beyond progression, or is it only abemaciclib? Dr. Cortez.
So we have 3 randomized phase 2 studies, Palmyra, PACE, both of them were completely negative. So Palbo after Palbo does not work clearly. And we have Maintain, which is Ribo basically after Palbo. So after Palbo, in my opinion, both Ribo and Abema are good options. We have more data with Abema now with imlunestrant or with the post-Monarch. And after Ribo, only we have data with Abema. So in my opinion, Abema is the most reasonable approach, but maybe for some patients we could consider also Ribo.
Right. So the Maintain-like approach. Does the OS benefit from Inavo trial change your practice in any way?
I think this is going to be the next standard of care for 2 reasons. And I was a little bit skeptical when you present the first data. I said, well, we have to see, because maybe the sequential approach could be also good. But when you realize the bad prognosis these patients have, with median PFS in the range of 7 months, and median overall survival 27 months, I think that we'll have to do something better quickly. So yes, in my opinion, this changes everything.
Yeah, I think this is the first time we are at least finally seeing some overall survival benefit with such an approach. And I think it's attractive to keep that in mind as we think about it. It's a smaller group of patients. And as Dr. Hurwitz was pointing out, we have to be careful about selecting the right patients who would be able to tolerate this therapy and manage the toxicities. But at least in those patients, otherwise they have such a bad poor prognosis that it just makes sense to use.
And also these drugs, neither Capiva nor alpelisib, nor everolimus, have shown improvement in survival in further lines. So I think this, in my opinion, this clearly changes everything.
And it was a beautifully designed study because it went after those patients who need this extra therapy the most. So we should apply it that way. But I agree, it's really important data.
Right. No, I completely agree as well. And I think a follow-up question, and I'll take that. I think It's about recommendations for preventing or managing the AEs with inavolisib we were talking about. I think, one thing that we see across this class is hypoglycemia, diarrhea, rash. So we see that with inavolisib as well. We also see some stomatitis. So hypoglycemia is the most important one, I think, in many ways. Despite a hemoglobin A1C of less than 6, so it's a very limited, pre-diabetic patient population that was studied here or not studied here, actually. And there are ongoing studies with that at this point to address this better. But the discontinuation rates for hypoglycemia were low, maybe because of that, right? It was 5.6% that had discontinuation for hypoglycemia. So that's the most important part of management with inavolisib. We want to make sure we look at the BMI, we look at the pre-diabetic, so check a hemoglobin A1C. Lifestyle optimization would be very, very important. Initiating metformin prophylactically even. We have the Metallica study from Spain that showed benefit to such an approach with alpelisib. So I think something like that would be very appropriate for patients, something we want to keep in mind. Diarrhea, I think we can do antidiarrheals right away. Rash, thankfully, with the inavolisib, we don't see any grade 3, so I have not necessarily considered doing antihistamines. It's very low-grade rash, if any, but we haven't seen rash as a main signal. And for stomatitis, where we see that with CDK4/6 as well, I think dexamethasone mouthwash helps. So I think that's something that we want to do when we start utilizing Inavo in clinic. Why do you think the new ER-targeting drugs have primarily shown benefit in ESR1-mutated tumors?
I think you said it just a few minutes ago. It's not that these agents don't have benefit. They're being compared to fulvestrant and AI, which are really good drugs, and that's where they get the edge. But these are really good drugs that are good anti-estrogen therapies.
Yeah, so it's not that it doesn't work in wild type. They're just not superior statistically in wild type because of the complexity and other mechanisms, the complex cascade that otherwise drives the tumor growth. I think in ESR1-mutated tumors, it's a little simpler in that you have a ligand-independent but a ER-dependent way of tumor growth. And so this works there and shows benefit there. But in wild type, there could be other feeders that are growing and making the tumor grow, so it becomes more complex. Are there any concrete criteria for defining endocrine resistance or sensitivity in HR-positive metastatic breast cancer?
So we do. So first-line metastatic means that sensitivity, patients with de novo disease, or patients who received endocrine treatment with a treatment-free interval higher than a year. This means sensitive disease. If not, they are resistant. Primary resistant when the resistance comes in the first 2 years on adjuvant treatment, and secondary resistant more than 2 years and lower than a year after the end. In second line, I think this is something that we should change, in my opinion. Today, it is established in 6 months. So when the patient does have progressive disease in 6 months, this primary resistant, more than 6 months is secondary resistant. Maybe sensitivity does not apply here. I think that in the era of CDK4 and 6 inhibitors, this should change. In my opinion, primary resistant should be 1 year and secondary resistant more than a year. But this is absolutely open for this class.
Yeah. Question about differences in AE profiles for oral SERDs and the main issues. I think overall, they are all similar in that some low-grade toxicities. There are some uniqueness to their toxicity profiles. For instance, camizestrant has very low-grade photopsia and bradycardia. Giredestrant has low-grade bradycardia. Imlunestrant has low-grade diarrhea. Elacestrant has low-grade nausea, which is more predominant, or hypertriglyceridemia that we keep an eye on. So some slight differences there. Overall, better tolerated, it seems, compared to our standard of care drugs when it comes to arthralgias, for example, or hot flashes. And so it does seem like patients are overall tolerating it well, but some nuances in their side effect profile that we want to keep in mind when we start using them. Another very interesting question is, if we have more than one approved, how would we choose? And how would we decide which drug to go after? I think here as well, I think, we have 3 CDK4/6 inhibitors, 3 aromatase inhibitors. We have 2 TROP2 ADCs already. So this is a problem we face in clinic all the time. And I think we make those decisions, again, a patient-physician decision-making process. If photopsia or bradycardia was something that was bothersome, then maybe we have another option to reach out for, or vepdegestrant to reach out for. the combinations might also drive utility, right? I think it's possible that if we have one drug which is also available as a combination or approved as combination, we're not going to think about that drug for combination only and not for monotherapy. And so that might shift our practice in some ways. But otherwise, I think the first kid on the block always gets the edge. So people are using elacestrant already, and it's very well tolerated also. And so I think, we're going to have the same thing. It took us a while to shift our practices from palbociclib. So we'll see what happens with SERDs when we have multiple of them. We answered the question about stomatitis with everolimus. Any barrier to using Inavo fulvestrant palbo because of the time it can take to get biomarker testing results? Great question. Tissue testing usually takes a little longer. ctDNA returns back in about 8 business days. So I think by the time you actually identify this patient, maybe you could even start them on fulvestrant, and then meanwhile you get the results and know whether you're going to go just the CDK route or do the triplet regimen. So I think 8 days is not bad. Let's see, we have multiple questions. I'm trying my best to get through as many as we can. What next generation SERD are you most excited about? Do you have a favorite, Dr. Cortez?
No, I think that all of them are good.
I think so too.
I think it's very important, the clinical trial design, and I would not like to make any comment today, elacestrant, because this is the only one which is approved. The toxicity profile is great. We saw the toxicity profile with imlunestrant, which is absolutely amazing as well. With Cami, we have these eye problems. It's nothing. And also giredestrant, the toxicity profile is very nice. So I think that in general, the toxicity profiles of all of them are very good.
Fantastic. Do you extrapolate an AVO 120 study to use a different CDK4/6 partner? Currently, I don't. We have the Morpheus trial that is evaluating abemaciclib and ribociclib as partners as well. But again, we have to await all that data to be very comfortably, using them. I feel like palbociclib has been a very easy partner when it comes to 3 drugs and 4 drugs. We have Patina with 4 drugs. Dr. Hurwitz did a fantastic discussion on the Patina results at San Antonio. And I think it seems like when it comes to multiple drugs as a combination regimen, palbo seems to be easy. So right now, I would not do that. I would stick with palbo. There's still a group of metastatic breast cancer patients that rapidly progress regardless of mutation status and current treatments. Do we have a sense about what is driving those tumors beyond ER, PIK3CA, AKT, or PTEN? Any thoughts on that?
So there are very aggressive behaving ER positive, breast cancers. And I tend to see them in BRCA1 carriers. And there tends to be other mutations. It's unclear if they're driving them, and we don't, outside of BRCA mutations, really have anything to target them with. We tend to end up going pretty quickly to chemo-based options.
Absolutely. And I think, we have those biomarker approvals for very rare alterations like the NTRK fusions with NTRK inhibitors or RET fusions with selpercatinib, or high TMB, again, very rare and HER2 positive, or neratinib with HER2 mutant tumors. And I think one thing I'd probably highlight, and that's the last comment, I guess, for the night, but P53 mutations can be as frequent, and they are aggressive biology. We can see about 27 to 30% HR-positive tumors with P53 mutations. And interesting work from our institution where we think about the first-line patients with CDK4/6 inhibitor. The middle part of the Kaplan-Meier curves are those patients that do not have a durable long-term response, right? They lack that. You have bad actors, you have good responders, and then the majority of the chunk in between. And P53 mutation there could possibly lead to this lack of durable response. And maybe CDK2 inhibition, based on the work done, could play a role there. So some role for selective cell cycle inhibitors in that space. So yeah, beyond that, I think we're still working hard to figure out what more we can do. Thank you for being such a fantastic audience.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, Living Beyond Breast Cancer. This activity is supported by educational grants from Genentech, a member of the Roche Group, Lilly, and Stemline Therapeutics, a Menarini Company Group. To access all materials for this activity, visit peerview.com/RAX860.